Hello everyone, we're back again with one more examination video. Today we're going to discuss cardiovascular examination. It's one of the very high yield ones, always comes up in your OSCEs and always important whether in adults or even in peds patients. Let's get started. We're going to try to finish this as fast as possible, although it's a dense, condensed one. So for general examination, we have to note for specific things or specific signs in the cardiovascular examination that you can't see or you wouldn't actually look for in gastrointestinal or respiratory exam. You would look for level of consciousness, assess the general condition of the patient. Are they in comfort? Are they in pain? Are they awake and alert and cooperative with you? If yes, then you move on and look for cyanosis, any pallor, any malar rash on the face. Usually it's on the cheeks. There would be some redness or malar rash on the cheeks, and this is associated with mitral stenosis. Any volume overload signs, and volume overload signs are very particularly of high importance because these patients need specific certain care because they're overloaded, they have right-sided failure usually, and you need to like diurese them and look for any other signs of organ failure in this case. So you look for pitting edema peripherally, so start with the lower limb as distally and then start palpating while going up. Look for abdominal pain or distension. Usually they can get ascites if it's very severe. Any jaundice or hepatojugular reflux, so on right-sided failure, they would be jaundiced. Their liver would be filled with blood, and this would cause a reflux into the jugular vein. So when you palpate the liver deeply, there would be a gush of blood into the jugular vein. Look for jugular venous distension. I'm going to demonstrate it in the coming slides. And look for hepatomegaly as well. In the eyes, you would look for conjunctival pallor associated with or indicative of anemia. Look for jaundice. Again, it would be seen in the sclera, and then for xanthelasmas, which are the spots or the tiny, small, yellowish spots indicative of hypercholesterolemia. Moving on to the hands, look for capillary refill. Is it delayed or not? Less than 2 seconds is normal. Look for the pulse and compare both sides. It's in cases of coarctation of aorta, you would get discrepancies in both sides. In one of the sides, the pulse would be delayed. And then look for clubbing, splinter hemorrhages, the dots that you find in the nail bed, and finally the Osler nodes and Janeway lesions in infective endocarditis. One way to help you remember this is the L I put here with painful. So Osler is painful, and then Janeway with the E is painless. So the E in Janeway associated with painless lesions. They're very similar. They're both in the palm of the hands and the fingers, but the pain is the differentiating point here. Then look for jugular venous distension in the neck, as we said. Check the carotid pulse if you couldn't get any peripheral pulse. And for jugular venous distension, what we're going to do is, this is the anatomy. It's over here. If your sternocleidomastoid is here, this is lateral to it. So you would go on and ask your patient to lie in 45 degrees. They couldn't be lying supine because in supine position, they wouldn't be it wouldn't be accurate because normally the jugular vein would be distended while lying supine. So I'd ask them to lie in 45 degrees specifically and look for, mark the spot where you see, mark the spot where you see the upper limit of the vein or the distension that you see, and then mark another spot at the sternum over here and put a ruler and see if it's actually exceeding this point or not. If there's anything beyond this point, this is abnormal. This 4 centimeters that you find here is normal, but anything beyond this is going to be abnormal or considered jugular venous distension. Moving on to the lower limb, again, we said look for pitting edema in the lower limb, look for ulcers and peripheral pulses, and this is usually for to screen for chronic limb ischemia or peripheral vascular disease. There would be faint peripheral pulses or there would be some arterial ulcers. Now for chest examination, we're gonna follow pretty much the same sequence: inspection, palpation, and then auscultation. There's no percussion in cardio exam because there's nothing much you're looking for in percussion. It's the heart is gonna sound dull and there's nothing you're looking for in percussion. So we're gonna stick to inspection, palpation, and auscultation. In inspection, we would look for surgical scars, such as this one here, median sternotomy scar. It's a very important one because it indicates open heart surgeries. So this could be a previous CABG, or it could be a valve replacement, a congenital defect, so many other causes that we can list here. So look for a median sternotomy scar and inquire about it in your history. Look for the pacemaker scar. A very small one would be there in the left upper part of the chest. Look for chest deformities like pectus excavatum and garinatum. We explained that in respiratory exam video. Look for the apex beat, whether it's visible over here or not, and look for any chest tubes or drains. Usually patients with pneumothorax or hemothorax would have drain attached somewhere there in the mid-axillary line. So inspect both sides for any drains attached. Look at the surrounding of the bed of the patient and note for any drains there. Then for palpation, there's a very specific technique we'll use here. So for the apex beat, you would use the tip of your fingers to feel the point of maximum intensity, particularly here in the normal location where we would find the apex beat is the midclavicular line, fifth intercostal space, exactly here at the intersection over here. So this is the midclavicular line over here and the fifth intercostal space. This is where you will feel it, but you try to use the tip of your fingers for point of maximum intensity. This is the most accurate way to feel it, actually, because this is where you can actually sense it the most, is the tip of your fingers. Then we would look for thrills and heaves. What are thrills and what are heaves? The thrills are palpable murmurs. So any murmur that is more than 4 in the grading system of the murmurs, any murmur that is more than 4th grade murmur, it's gonna be giving you a thrill on examination. What's a thrill? The thrill would be felt by the base of your palm. So when you place your hand, try to look for it in the base of your palm. In contrast, heaves are again indicative usually of enlargement. So usually you would get the RV achieve, the right ventricular hypertrophy heave. It would be felt here at the parasternal, left parasternal area, particularly here. But how would you feel for it? You would feel for it with these specific points in the metacarpophalangeal area of your hand. You would place it and you'd feel it, but the base of the heel is usually, the base of the palm usually is used to feel for thrills. And finally, if the apex beat is displaced, so this is indicative of LVH, left ventricular hypertrophy, usually in cases of chronic withstanding hypertension. That's one very common differential for it. If not, you would feel it here. If it's displaced, it would go somewhere there to the mid-axillary line. Then for auscultation, these are the 4 main areas that you need auscultate for, although the valves are anatomically not in these points. However, this is where you will auscultate and hear them. So right second intercostal space for aortic, left second intercostal space for pulmonic, and then lower left sternal border is for tricuspid, and the at the same site at the apex beat in the midclavicular line, fifth intercostal space, is the mitral valve. Now, what are the murmurs that we need to note for? This is very important. I tried to put the important murmurs for you here, but there are so much more to this. There are other differences or other murmurs that you can hear. There are congenital heart defects that have certain murmurs. I tried to summarize here only the the valvular disease murmurs only, but we could discuss the congenital heart diseases later. So for semilunar valves and for AV valves, I would want you to differentiate between the two. Usually the systolic murmurs are either stenosis of a semilunar or regurgitation of an AV valve. So this is how I would like you to connect them together. So any systolic murmur is usually either regurgitation of an AV valve or stenosis of a semilunar. So aortic stenosis usually gives you an ejection systolic, while mitral regurg gives you a mid-systolic. In contrast, diastolic murmurs, usually the semilunar regurgitation or the AV valves stenosis. So in mitral stenosis, you would get a mid-diastolic rumble, and in aortic regurgitation, you would get a late diastolic murmur. So you can divide them into diastolic and systolic and differentiate them accordingly. That was it for today. Thank you guys for listening, and we'll get back to you in another video shortly.